So thank you for inviting me to speak tonight. My name is David Gendelberg. I'm an assistant professor at UCSF at the Zuckerberg San Francisco General Hospital. And I'll go over my experience with board collection. So I've kind of divided this based on the timeline of board collection, and we'll kind of go along and talk about my personal experiences and advice for each phase. So pre-collection. Everyone kind of talks about this as like the golden period to kind of do what you need to do and whatnot, but not quite. I kind of see this period as kind of like the practice for the big race. You really want to utilize this time to kind of get into your groove, familiarize yourself with the system. Most of you will be in a new hospital, so you want to know the OR, make sure they have the equipment you need, get to know the EMR, how your clinic functions, so that when you get into board collections, your cases run as smoothly as possible. You also, during this period of time, want to know what works for you and what doesn't work. You want to hone in your skills and kind of figure out what indications you're going to use for surgeries. And you also want to make connections. You want to know your colleagues and people from the community, and kind of get that support group, so to speak. During the board collection, one of the big questions is, how do you choose your cases? On the one hand, you want to have enough cases to meet your minimums, but you also don't want to be reckless. So you want to have tight indications are vanilla, as Byron said. You want to really follow the book, be conservative. You don't know who's going to be testing you and what their thought processes and opinions will be. And really, you want to consult with your colleagues and your mentors. And if you're not sure of what to do, I have like multiple text groups where I just discuss things with my friends and mentors and run things by them. And for the complex cases, it's good to co-scrub with one of your partners. Documentation is key. This could literally make or break you. You want someone who's reading through your notes to know why you're doing what you're doing. You want to document potential alternatives, risks, and expectations. I work at an academic institution. I always dictated in my notes that being an academic institution, we would have fellows, residents, and med students scrub into the case, and they would participate to the level of their ability under my direct supervision. And also, I can't tell you how many times I've seen subpar physical exams documented, and that could also make you or save you, given the situation. And kind of echoing what Byron said, you really want to make sure your consents are like nice and clean and clear. So complications, you're going to have them. For the board purposes, anemia, delirium, and hypokalemia are all considered minor complications. I worked at a big level 1 trauma center. Out of my 12 cases, I had 4 deaths, and I think 9 or 10 of my patients had one complication or another. Granted, the deaths were they were unavoidable, but my point is complications happen. And it's really how you explain them, and what you do with them that the board examiners pay attention to more. So if a complication happens, talk to the patient, be honest, assume responsibility if necessary, contact risk management if necessary. Don't try to hide them or like brush them under the carpet, and document everything. And really, if something big happens, don't let it affect your future cases. And as I said, complications do not mean failure. When you see the patient in clinic, the board examiners really like to see your documentation. It seemed to me that they really wanted to also see what the follow-up plan was for every note, and explaining whatever tests I would order. being a big trauma center, I had many patients that were lost to follow-up. And so I was asked what my clinic's protocol was to follow up with patients. And it's kind of good to know what your clinic does when a patient no-shows or something like that. So now you have your 12 cases selected. Now what do you do? So you want to provide all the relevant information in a concise manner, but you also don't necessarily have to give every detail and flood everything. For instance, if you did a case and for some reason the medicine team ordered a chest CT and it was revealed that you have a asymptomatic medial breach of a screw, I'm not sure you need to go in depth into that on your case summary. Provide your rationale. You want to know the testers to understand your thought process and know why you're doing what you're doing and why you chose that selected treatment, and you really wanted to have a good flow. So now you've got it all down. You're preparing for the exam. Now it's time to make a script. You want to rehearse that script and you kind of want to present it to your mentors or other people. This is really the time to work out the kinks of your presentation. I've had multiple colleagues present their cases to me and I've provided them with feedback and they've done the same to me. And I can't emphasize how valuable that it has been. And you want to read up on applicable general concepts. I mean, really the exam is kind of a free-for-all in terms of what they could ask you. So you kind of want to know the basics. You want to know your classification system, alternative treatments, contraindications. You want to know the literature, but you also don't want to like cite a paper because the follow-up question to that will be asking you for more details about that paper. So if you're going to mention a specific one, you better know it cold, but like Byron kind of mentioned, I would just say some of the literature suggests and kind of keep it general like that. And also know some of the medical background for your patients. I had a patient who had HIV and I was asked about HIV pathophysiology and management. So when taking the exam, I took it online. I'm sorry, I didn't go to the Palmer House, even though I've heard it's quite the experience. And so you want to provide, kind of like in residency, you want to provide sufficient information, but also leave room for questions so they could ask you the low-hanging fruit and kind of get in your groove. You want to be humble. If you don't know the answer to a question, say you don't know, I'll look that up. It's a very good point. And as I said, like, it's okay to have complications. They want to see that you learned from your complications, that you did something differently, or how you managed it. So since that complication, I have changed my practice in this way to help minimize the risk of that happening again. This is what I've learned. And really, you want to just stay calm, don't get flustered or amble, and be concise. After the exam, don't contact the examiners. I know that that's obvious, but things have happened. What was done is done. Keep practicing the way you did during board collection because it's generally good practice. And also, in the event of failure, your past cases that you've already done will retroactively become part of the next board collection period. So until you pass, just be careful and act like you're under board collection. And so a couple of final pearls: establish a good workflow. Complications do not equal failure. Build a good team of peers, consult your mentors, rehearse before the exam, be concise but clear, and be humble. Thank you very much.
David, thank you. And Byron, thank you both for coming tonight and doing this. This is very, very helpful for us. This is kind of a black box on our end and everybody kind of assumes the worst. I guess, David, for you first and Byron also, was there anything that happened that day? I mean, obviously HIV questioning is a little out of left field for me, but was there anything else that kind of happened that day, questions they asked or things where you weren't thinking they were going to kind of go into before you started?
You know, I remember I had one case. It was one of my partner's cases that had a symptomatic medial breach that I ended up revising. And all I did was a screw exchange. And that led to a whole discussion of what would happen if CSF came out of that screw hole. And then led to me explaining how to put in a lumber drain and what flow rate. You know, it's really tough to predict some of these things. I was asked about certain strains of MRSA, and I was like, you know, I'm not familiar with the substrains. I'll have to look into that. Thank you for opening my eyes to that, you know?
Yeah, I would echo that. I think I had one examiner who was pretty hard, and the others were all very reasonable. And I don't know if this might be a difference of it being in person versus virtual exam, you know. But I had an examiner who you could tell on every case and every discussion point we had, he was going to push me until I had to say, I don't know. But as soon as I said, you know, I don't know the answer to that. And it was, and I can't remember specifically. I remember who it was, but I don't remember the specifics of the questions he was at. But it was absurdities like what David was saying. Tell me the pathophysiology and the mechanism of action of the HIV medication your patient's on. And that's all that is meant to do, in my opinion, is to fluster you and make you sort of, to get a reaction. That's my opinion. I had one examiner like that, and you got to be comfortable in knowing what you know and being able to say you don't know what you don't know. And it's an opportunity to demonstrate your knowledge, and you should know a whole lot about indications for spine surgery, how to do the spine surgery, how to manage postoperative complications. I would not lose sweat at all if somebody asks you about the kind of things that David's examiners asked him about. And I will say, in my experience was very different than that. My experience was this is very fair, and it was very 10,000-foot view. We got to realize you have very little time, right? There is very little time to talk about each one of these cases. And I remember I had it all scripted, but I had so much information, and they want to hear the story. They want to hear why you did what you did. They want you to show them the X-ray, and then they'll ask you some questions. And in my experience, the questions were very benign. But I did have one examiner who pushed me a little bit, and he just wanted to push me to my limit, and for me to tell him I was at my limit.
Yeah, it's actually interesting you mentioned that. So I did it online. So I had it on 2 separate days, and the 2 days could not have been different. My first day, I felt like after the exam, the examiners were gonna take me out for like scotch and cigars, and the other day was like much more intense. I think also one of the big differences is online, they get to see your cases ahead of time. So they kind of get to prep for it, while my understanding is in person, that's also the first time they hear your case.
Yeah, I think in person they were supposed to review them, but you could tell they were very much dependent on, hey, let's move on. This next case, tell me about what, so yeah, it's very different, and it's interesting hearing your perspective. And I think obviously this is the world that we're in now, so it's good to prepare for it.
Thank you. That's really helpful. I don't know if there's any other questions.
Doesn't seem so. So now what we are going to do is that we have Dr. Gendelberg and Dr. Stevens with us, as well as everyone who is participating on the chat. We are going to go through various case presentations to supplement our discussion. These are in no particular type of case, and they are to gain or garner good conversation about being a new surgeon and trying to approach each situation in maybe even just a board collection type situation. Some of these cases do have endings and some of them don't. So we would love to hear from the chat if there's any specific questions. We're going to kind of just go through them slowly, and then David and Byron can jump in as needed. So the first case that we're going to go through is a 37-year-old female who presented to clinic with a month history of neck and arm pain She rated it about 80/20. Unilateral right upper extremity was worse than left. She had been previously seen by one of our hand colleagues who was working her up for cubital tunnel syndrome, but otherwise had no relevant past medical history. She was not in any accident preceding her event, and she works locally as a hairdresser. On physical examination, she has 4 to 5 strength to the C7 nerve distribution on the right upper extremity, otherwise intact, and she has a negative Hoffman sign. These are her X-rays. She's nice and thin. Anything jumping out? I don't really see anything jumping out, and we can kind of roll through this a little bit quicker, but she had no fracture abnormality and otherwise normal. On flexion extension views, there's no evidence of retrolithosis or anterolithosis. At the level of concern that we would probably be honing in on, graded on our exam, would probably be 6-7. My radiologist likes to put a bunch of things that I can't get rid of. I apologize. So she goes to physical therapy and she comes back and she presents with this MRI. And what you can see here is we're centered over the C6-7 disc space. And on the right side, she's got some foraminal narrowing consistent with her exam. Maybe each one of you, David and Byron, what would be your general approach at this point? We've got a youngish lady who works as a hairdresser, but she's done physical therapy. She's still kind of miserable and a little weak on the right side.
Personally for me, the young patient, I started thinking about, motion preserving options. Things, this would be a great patient, I think, for a cervical disc replacement. It's also a pretty far lateral disc. I think the posterior cervical foraminotomy is another surgery this would be a reasonable option for. You can see it's a well hydrated disc. Little surprising, it hasn't gotten better with conservative treatment, but that's the way it goes. So I think both of those are viable options. This is a perfect case to torture people with at boards, because they'll ask you sort of the relative pros and cons. I don't know, David, what do you think?
I absolutely agree. You kind of took the words out of my mouth. Another thing that they may ask you is what would push you to do an ACDF versus a disc replacement, and what your own personal indications would be, and maybe how you would manage them differently.
Currently, I am more proficient, obviously, at an ACDF. I'm more comfortable with doing an ACDF. I think in board collection, I'd have a hard time doing a disc replacement, just because I'm not as proficient with it. And I feel like I would be a little more conservative with that. But I think Dr. Chapman has a question or input.
Sorry, thank you. I'm in the OR. I think this is a great case of controversy, because as we talked about board reviews, and I don't want to tell you what to do, I think the surgical discussion is a great thing. But as somebody who used to do this is the kind of a case where I'd really want to see a young orthopedic colleague kind of own the non-surgical care and be very careful to take that step towards surgery. And so I'd want to have some discussion about, quote, owning the non-surgical care. Because if I send my patients to PT and say they've done PT, that means just about nothing. And I have zero neck pain despite having been in the OR all day here. But if I do some of those PT things like resistive exercises or the owl exercises, I will have neck pain today. So the whole point is, I think that we should be very careful. We should probably own more of the PT. We should have more sensible input as to expectations and deliverables, and also self-help exercise on the part of patient, like traction, shoulder girdle rehabilitation, things like that. And then be a little bit more careful in terms of possibly also using selective nerve blocks. Many people say without steroids even, to kind of have a better picture of the patient's ability to actually respond to what sounds like a ridiculous symptomatology. If there's true weakness, then especially now as we have so many side reactions to immunizations, being very worried about parsonage Turner type syndrome. So having probably a lower threshold towards electrodiagnostics might be a good discussion. So this is a C6-7 area, but C5-6 and C6-7 are these two notorious areas where we may mistake a patient's ridiculous symptoms as discogenic in the presence of a relatively harmless disc, when in fact there is a brachiitis or a immunologic side effect present. So summarizing my statement, I just want to make a plea prior to jumping the surgical gun to really being circumspect and being far more hands-on involved in terms of setting expectations for rehabilitation and being careful about selection of diagnostic things. And with that, I'll end. Thank you for letting me speak.
Thank you.
Thank
Yes,
you.
I absolutely, oh, sorry.
No, go
I
ahead.
absolutely agree with that. The one thing that to me is a bit more concerning is her weakness, and that in my mind makes me a bit more tempted to go the surgical route than prolonging the conservative management for too long.
Yeah, I think too, you got to be really cautious about the timing, right? I forget the exact timeline on this case, but don't take hot discs to surgery ever, right? Because 80% of these people get better no matter what you do. It's the natural history of this disease.
Yeah, I think it was like a month and a half or two.
Yeah, her first presentation is about a month out of her symptoms, but this MRI is probably within 2 to 3 months after seeing her originally. So she's early.
Yeah.
But she says that she can't hold her arms up. I'm a daughter of a hairdresser, so she can't hold her arms up to work. She hasn't worked in like 6 weeks. There was a discussion about a selective nerve root block, like Dr. Chapman had said. And I didn't mention, but because she came from our hand colleagues, she actually got an EMG prior to presentation. So we did have some other information that I didn't divulge. But for the sake of time and more interesting cases to come, what ended up happening is that maybe not. Oh, and that's just showing the preferential frame in view. And we talked about our next steps. A lot of us are advocating for continued non-operative management in her, or a motion serving procedure. She underwent a C6-7 ACDF, which she tolerated the procedure really well. Her arm pain completely went away, and her weakness resolved probably within the first 2 to 3 weeks. She kind of regained her ability to hold her arms up to perform surgery. Excuse me. My mom prefers surgery to perform hairdressing. And she went and ended up healing without issue. These are her flexion extension films. All righty.
By the way,
Yeah,
Kat,
yeah.
Sorry.
Go ahead.
I think that's a great case, Kat. And if you go back, I just had a question, Byron and David. When you're looking at disc arthroplasty as an indication, I think this one you don't. I mean, she had some loss of cervical lordosis, but her alignment's reasonable. The disc height, it seems like a soft disc herniation. Is disc arthroplasty, would that be under the bucket of like a tweener in terms of controversial, not controversial, just in terms of use of that device as a treatment?
I think at this day and age, one level disc replacement under the proper indications is perfectly accepted.
Totally agree. It's totally fine. I would, cervical disc replacement. Yes, there's plenty of. It will spark a good conversation with your board examiner. I think it's totally fine. I will tell you, when I was sitting in your shoes, I wouldn't have done it. But I, on the other side, it is 100% fine and defendable. Lumbar discs are a different story. I would not recommend anybody do that.
And Kat, I just want to say you gave a wonderful answer when we asked you about ACDF versus disc, in saying, in my hands, this is what I'm better at and what I'm more comfortable doing. That the examiners love hearing that answers. And I think that is a perfectly, on my exam, I did a T-lift and I was asked, why didn't you do an X-lift? And that's the exact answer I gave. So good answer.
Thanks, David. All right, Jim, you ready?
Yeah. Thanks, Kat.
I'll just go for it with you, and then you just tell me.
That'll work. Yeah. This won't have as robust discussion about indications, but it's kind of interesting. I chose this case for reasons involving kind of the infrastructure of where you work. So just a quick preface. I am an alum of Emory, just like Byron. And I actually remember we did a complex case conference a few months back that Byron actually came and presented at, which was great. And I'm working as the solo orthopedic spine doc in my practice. I'm in a community hospital. I have a couple of neurosurgeons that do spine cases as well. So this gentleman was a 59-year-old guy, blue collar worker. He's had a long time of low back pain and some right-sided radicular symptoms. A lot of it improved overall, but one of the things that did not improve was his weakness. So he had pain at first, the pain got better. It seems like there was kind of this acute exacerbation, probably the instance of a disc herniation. And then like we were discussing before, he probably fit in the 80% range where it got a little bit better. He's a refrigerator salesman, so he's going up and down steps every day. So with the quadriceps weakness, he's absolutely miserable. Relatively healthy guy. He did have CAD, so I had him evaluated with cardiology, but not on any pain meds. Real kind of tough blue collar guy, doc. I have a tough time getting up and down steps. I can't sell what I'm trying to sell, and I got to feed my family. Next slide. So we start with the X-rays, relatively benign. I did see some, I always make sure to comment about kind of the calcification anterior vessels, just kind of some harbingers of areas that I'd be concerned about just on the X-ray. But, generally kind of a loss of overall lordosis, kind of a stenotic guy at baseline, but young guy. Next X-rays. Not really much motion on flexion extension views as well. Next slide. So at the MRI, I'm looking in and around 2, 3, 4 in this region, and I see a little bit at 4, 5, a little bit about 3, 4. And then I'm kind of looking, if you look right behind the vertebral body of 3, next slide, there's this little chunk of stuff right there. And actually, when I talked to the guy, he presented with 2 MRIs. And I asked him, well, why did you get 2 MRIs? And he's like, oh, well, my primary care said the first MRI wasn't good enough. And I was like, good. I'm not sure exactly what he meant by that. And so, of course, we take a look at the read here. Next slide. And this is the second one, with and without contrast. And a lot of verbiage here consistent with our radiology colleagues, but kind of the second or third sentence here, lesion may be a nerve sheath tumor. Not only that, but less likely a disc extrusion. Mets can't be excluded. This could be anything. It could be a bullet according to them. But, basically they're just saying this is probably a nerve sheath tumor meningioma. So I'm seeing a guy who really has no risk factors. Otherwise, musculoskeletally does not look abnormal. And we're kind of looking at a read that's showing kind of this atypical lesion that I feel is probably involved in this weakness. So check the next slide here. Yeah. So what are your guys' thoughts? You got this read, you've got this young guy with some weakness. It got better with, yeah, I think this is the perfect slide, Kat. And you see kind of this lesion here. What's kind of your thought process? What are you doing before, things that you would do preoperatively before you go to surgery?
I mean, I think especially since they mentioned the nerve sheath tumor, being orthopedic trained, I would definitely want to get the opinion of a neurosurgeon.
Yep.
I agree. I think this is a great case to reach out to your colleagues and build a relationship. Probably want to get a CT myelogram is what I would guess. I don't know. I've seen a lot of disc herniations look like this. I'd have to see the contrasted images too to know how great I'd be. I'll tell you, I took care of a lady with a very similar pre-op MRI. Of course, I see these people, so it's a self-fulfilling prophecy. But who had a primary bone tumor that presented much like this. But I think getting consulting with one of your colleagues, getting probably a CT myelogram is the way I would go.
Great. Yeah. So I did that. So if you go to the next slide, here's kind of my thought process. So I think it was just a decompression with the discectomy. First thing I did was call neurosurgery. They said it was about 99% sure is what he told me, that this was an extruded disc herniation behind there. And they were totally on board. So it's actually one of my colleagues that works in this spine center we're developing. said, I'll be available if you need me. I'm happy to help. And so he was actually around the hospital and also kind of scrubbed in and checked in with me. After talking to neurosurgery, I talked to the patient, let him know, hey, you got 2 MRIs because of this. He didn't really care too much. He just wants to keep selling refrigerators. And then the third thing I did was talk to the OR, just got kind of a review of what we have and don't have about durotomy repair, or if this is an atypical lesion, or if we come up against something that's tough, and have what other instrumentation do we have available? What are we going to deal with, and then send it for pathology. The CT myelogram is a good point. They actually, I did not recommend that with the neurosurgical colleague. He said it wouldn't change his management. But I was kind of thinking along the same lines, but I had him with me, so I thought that would be reasonable. So next slide.
And obviously I would document everything that you did and your rationale and the discussions with the patients and the neurosurgeon. So it's kind of clear you covered all your bases.
Yeah, that's exactly what I did. So all 4 of those things were kind of in the documentation along with kind of my preoperative discussion. This is a familiar finding for Emory alums, but you have your pre-incision localization. Next slide. And then another localization. If you want to look dumb, you can leave your suction in the way. So just being mindful of things like that. Next. So yeah, we do the hemilotomy, partial medial facetectomy, you kind of feel the pedicle come down into the space, and it felt like something was behind there. Nothing was pulled out. And the other thing I did was I measured it. And that's one of the things the neurosurgeon said. He's like, listen, if you're really thinking this is what it is, try to compare it to whatever the preoperative read was. We got it about 2.2 centimeters. It was 2.1 according to the radiologist. So we felt very comfortable that we had kind of come across what we needed to. Next slide. And that's kind of what this goober thing looked like. And it ended up being kind of this extruded disc herniation with some fibrinous tissue. So, I informed the patient right afterwards. I documented talking about it, but just something, it's interesting. You're not busy, but then sometimes you just have a couple of, funky looking horses, giraffes, zebras, things coming in, and, you have to, I thought it was a good study in, like you guys are saying, find help and come up with a game plan and come up with, something, if something bad's going to happen, make sure people are ready for that. So there's no surprises on the day of surgery.
Now, I will say you may have an examiner ask you, okay, let's say you pull it out and now you have CSF and you've got a leak ventrally. What do you do now? Walk me through it. They may ask you to do that. What if you can't do a direct compare? What if it's a defect? They may ask you if you took it out and it turned out to be a tumor. What would you do then? Sometimes they like asking those hypothetical scenarios.
Yeah. To be honest, I'm not sure about the first answer. The second answer, actually, I talked with my neurosurgical colleague about it, and he said that most of the time you would then perform kind of an intradural examination and then evaluate the space. If there is a durotomy ventrally, that'd be a little tricky. I'm not exactly sure, but that's a great point. Just something I would have to think about.
Yeah, on each day of my exams, I was asked about managing my whole algorithm for managing CSF tears, from simple repairs to what if it's irreparable.
Yeah, gotcha. No, that makes sense. And then this is just kind of my post-op follow-up. And a question to both you guys. What do you think is a reasonable follow-up plan for decompressions? I usually do 2, 6, and 12 is what I've done early on. But I just wanted your guys' thoughts.
Yeah, I think that's totally reasonable.
Yeah.
Make sure that there aren't specific guidelines that have changed. I only follow decompressions for 3 months, but make sure that the boards don't have some other requirement.
Yeah, I think that's reasonable. You could also dictate at the 3-month mark, follow up in 3 months. If doing well, they may cancel the appointment.
Gotcha.
All right, Chad, are you ready?
Yep. So mine's a little change of pace here. It's more of a kind of, should we do this in boards or not? So this is a 49-year-old lady who had been treated by one of my partners for years, actually, for scoliosis and also some radicular symptoms that she was getting. Injections for that were kind of fading as far as how much relief she was getting. and she was doing PT on and off as well as home PT. And she came back in saying that she has a ton of pain now, really prevent her from doing anything in life. She was the main caretaker for her father, and really couldn't do much of anything just because she was in so much pain. A previous visit several years ago, she was actually offered a different surgery. I think it was a T12 to L3 fusion, but she elected at the time not to do it. She would rather just treat non-operatively with the PT. And again, she was doing okay at that time. So she came in to see me. She was otherwise fairly healthy, young, healthy lady. She did smoke a pack a day. But on her exam, she really didn't have anything as far as motor deficits, just a lot of pain, mostly back and then also somewhat in the left buttock. We can go to the next one. So these are her standing films in the office. I apologize. I have very few images. We actually had our entire system go down over the weekend, and it's been a rough couple of days, but this is kind of the best I could get were these and then the next images. So she does have the scoliotic deformity with some lateral aesthesis of 3-on-4, 2-on-3, and really kind of a loss of her lordosis as well. Unfortunately, I couldn't put any measurements on here, but her curve did measure, I want to say it was just about 50 degrees for her thoracolumbar curve. You can go to the next slide there, Kat. So her bending films that we got several months ago, you see she does straighten out fairly well. But again, she does have the lateral aesthesis and asymmetric collapse. Go to the next slide, Kat. We did get MRIs of her T and L spine. Just showed a remote compression fracture of L1, which if you look hard at those other images, you can make out. It's not all that impressive, but it is there. And as well as some foraminal stenosis at 4.5 and 5.1, more so on the left than the right, with associated kind of broad-based disc bulges. Next slide, Kat. So due to her L1 compression fracture, and she at one point had a atraumatic tibial plateau that was treated non-operatively by one of my partners, did send her for a DEXA scan. Interestingly, it only came back at -1.3. But due to the compression fractures and the plateau,
the DEXA scan, what was -1.3?
I want to say it was her hip was 1.3.
Okay, because that's another thing. You want to make sure you're looking at the femoral neck and not necessarily at the spine DEXA and whatnot.
Yeah, it was not her spine.
Okay.
And like I said, L1 had a compression fracture anyway.
Yeah.
But because of the two kind of atraumatic fractures, did treat her for 3 months on Tymlos. She completely quit smoking, and we did a cotinine for that, and she in fact passed it, which I was surprised by. So she's now completed, over that time period of all this different treatment, 6 months of physical therapy, and before that, several years of in-person and home PT, as well as other conservative measures with injections. I think at one point she even had medial branch blocks. So she's been kind of through the ringer as far as conservative treatments. My question now is, number one, would anybody elect to do any surgical treatment of this lady who's 47, I want to say? If so, what would you do? And if you would you do that during board collections, or would you do it under a partner's name who had already treated this
Well,
lady?
let me tell you what I did and what I would probably do now. What I did during board collection with these patients is I did them with my partner. I would tell you I wouldn't be afraid of this case. Chad, you almost sound like you're apologizing, for showing this, and it's fine. And this lady has a progressive deformity. You measured it over 50 degrees. The natural history of that is that it tends to progress. She has radiculopathy and a concavity of her curve. Don't apologize. Have a good reason for doing what you've done. I mean, you've clearly outlined that she's failed extensive conservative management. You've been thoughtful about her DEXA score. She's on an anabolic agent. I got no problem with you doing this surgery, and I'll tell you, don't be the wimp that I was, and do it yourself.
Yeah, I absolutely agree. I don't think it's the size of the case. It's really more the indication. During my board collection period, I did costotransversectomies, corpectomies for osteomyelitis, did a lot of big cases. The key is just having sound indications and being able to explain and defend what you did. The only one discussion point I'd have over here is you could have the discussion about whether doing focal decompressions initially and then a bigger case versus just going to the big deformity correction initially. Considering most of her pain is back pain, I'd probably be leaning more for the longer construct deformity correction with her, but that could be something to discuss.
Mhm.
How aggressive, David and Byron, if this patient, say, you could get away with a short segment, decompression or a short segment fusion in the setting of a deformity, would you be more inclined or less inclined? I think that her true nature is obviously, as Chad said, is more of a deformity case, but if you have like a degen scoli that has, isolated stenosis that you could treat with a short segment fusion and ignore the scoliosis, would that be something that is too board aggressive or seems reasonable?
I'd say the younger patient, I probably wouldn't go short segment. If it was an older patient with all the health issues and if it were like, 75, 80-year-old or something who didn't have that much longer, let's say, or not as much left as a 40-something-year-old, you can make the point of decreasing the risk of surgery, blood loss, and all of that. But I think someone who's 49, by doing a short segment in the middle, fusion in the middle of the curve of this patient, you're kind of asking for further surgery down the road. I think just a isolated decompression would be also appropriate in this patient. But I think if you're going down the fusion route in a young patient, you should probably address the deformity.
Where are we talking about doing isolated decompression in this patient?
My question was theoretical.
Yeah, I would say this. I think you can, as long as you have a good reason for doing what you're doing, there's a lot of things you could do with a patient like this. Personally, a decompression in the concavity of any significant deformity is something I'd be wary of in a board collection period.
Absolutely.
It's almost better to, it is better to fuse that patient, right? They're going to roast you if you do a decompression through a structural deformity, in my opinion. As far as what I would do in this specific case, this is probably a T10 to the pelvis for me, all posterior T lifts at the bottom, probably the bottom level or two for me. The bigger things from a board examiner standpoint, they're going to ask you, about biologics, right? And BMP, I would tell you don't shy away from it. This is actually this is a case where there's some off-label things that maybe I shouldn't be talking about this, but the reality is there's a lot of evidence for BMP, right? In this indication, it is cost-effective in preventing reoperation hardware failure in this patient. Period. You had an off-label discussion. You had them, sign an off-label consent form. You thoroughly detailed how you reviewed all the pros and cons and the risks and benefits. Don't be afraid of that. Okay, just have a good reason for it.
And absolutely. I would also go for the deformity correction in this patient. I was just bringing that up as kind of like a potential discussion point of the thought process. Another thing to consider is doing it all from the back or doing a 1 or 2 level A lift as well at the base. That's another thing to consider. There's no right or wrong answer.
Yeah, I think I was planning doing anterior posterior if we come to that, but different discussion.
Yeah, and they may also, and I think you did a good job with the team loss and everything. They may ask you what your protocol is in patients with osteoporosis and what your cutoffs are, or with smokers, what your protocol is and whatnot. But I think you addressed that pretty well.
Thank you.
That was perfect, y'all. We are right on time. So if there's no other questions, we might have one. You can claim credit. It's in the chat box. And thank you everyone for attending. And we'd like to thank Dr. Gendelberg and Dr. Stevens for joining us for our Young Surgeon series. We got one last question. Sorry, as I wrap up. What is the opinion of the panelists on SI joint for the source of buttock and back pain? and the pros and cons of fusing the SI joint.
Personally, I think in your board collection, that's something you really want to stay away from. That's my opinion.
Likewise, I mean, to get me to kind of do the SI fusion, it would be more due to process of elimination, but I would be very hesitant to do it during board collection just because there are a lot of thoughts and opinions about it.
Great. Now I can wrap up. There's no other questions. Thank you very much, y'all. We will see you in a couple of months for another Young Surgeon series.